Yeah, 1 minute to go. Srikant, Shekhar Das, sir is here. Srikant, YouTube live has started. Srikant, YouTube live has started or any problem you're facing?
Yes, some issues are there. So I'm trying.
You are done?
Yes, yes.
Okay. Okay. You raise the curtain. Shekhar Das, sir is there. Hello.
Yes, hello.
Yeah, sir. You are done. You have come. Okay, right. I could start the session. Second, could you raise the curtain, please? Okay, so we start the session, right? Okay, so I'll give an introduction of yourself. Just give me a minute. So good evening, doctor. I, Chayan Majumdar, on behalf of Jaidas, will education. We believe a case-based discussion. For today's IBS Charcha is a case-based discussion on
Chayan, hello. Chayan, hello. Chayan, Hello.
I think some network issues are there, I think.
Okay. So let me introduce the doctor. Good evening, doctor. I'm Sachin Lohar on behalf of Zydus welcomes you in IBS Charcha.
Yeah.
You know, doctor, IBS symptom manifestation is varied patient to patient. We believe a case-based discussion will be essential in your practice. Therefore, today's IBS Charcha is a case-based discussion on IBS. It is my pleasure to have Dr. Sandip Pal as a speaker of today's webinar. Dr. Sandip Pal is a senior consultant of gastroenterology and hepatology department and Rabindranath Tagore International Institute of Cardiac Sciences, Kolkata. He is a life member of ISG, INLS, and SEGI. He received various awards like Young Investigator Award in ISGCon and Travel Fellowship Award in INALSA. His research papers were published in renowned journals. Once again, we believe today's IBS Charcha will be useful in your day-to-day practice. During this webinar, you can post your questions in the chat box. Now I request Dr. Sandip Pal to start today's IBS Charcha. Over to you, sir.
You can share your screen, sir.
Hello. Can you hear me?
Yes, sir. We can hear you properly.
Yeah. Good evening, everyone. So first, let me share my screen. You have to allow me. The host has disabled screen sharing. Please allow screen sharing.
So now you can do that. Now you are the co-host.
Okay. So can you see the screen? Is the screen visible?
Yes, it's visible, sir. Yeah, I can see your screen.
Okay.
Yes, sir. Your screen is visible properly.
Yeah. So good evening, everyone. So thank you, Zydus, for the opportunity, and I would like to thank you for the kind introduction also. So today's topic for discussion is IBS, irritable bowel syndrome, a case-based discussion. So what I have done in this, what I will do in next half an hour is I've got a case which was admitted with us or was under my follow-up for last almost 6 months. And she is so it's a female patient. So she is from our profession. She is a nurse by profession. So what I will do is I will discuss this case and followed by some theoretical discussion about IBS. So I will stress mainly on the upcoming drugs or the newer drugs, you can say, for irritable bowel syndrome. So my patient today is a 52 years old working nurse by profession, and she presented to me with a diffuse pain abdomen, which was mild to moderate, not severe pain, bloating and with altered bowel habits, unclear stools, and predominantly loose stools. And the onset of abdominal pain, bloating, gas, loose stools on occasion for about the duration is around 15 years, but of late in past 1 to 2 years, this has increased. And the symptoms are all postprandial, and the bowel movements are usually on an average normal days, it's about 2 times per day, but it can increase up to 4 to 6 times per day with pain. And stools are formed on good days when there is no pain, but when there is pain, the stools are progressively become loose. And the location of the abdomen is predominantly lower abdomen, periumbilical area and the lower abdomen, and it's relieved after passing stool, and it's precipitated by food intake. She also complained of many other constitutional symptoms, like she always complained of giddiness, generalized weakness, disturbed sleep, anxiety. So all these things she complained of. And she had a history of 4 hospital admissions in last 1 month for the pain abdomen. Now, as you can imagine, she is a nurse by profession, and that too she works in a cancer hospital. So, so her thinking is that she is developing some malignancy in the abdomen. So for that, she was too much worried. She was anxious, and she used to avoid leaving home or eating outside because of her symptoms. But there was no history of bleeding, nocturnal diarrhea, or weight loss. and there is no positive family history of any significant disease. And the significant family history in the sense that she lives with her husband and she has got 2 daughters, both are doctors, but they don't stay with her right now. They are away for studies. And so this is about the history. So on examination, so when we examine the patient, she has got a mild abdominal distension and tenderness of the abdomen in the right lower quadrant. All her blood reports, the routine blood reports are all normal. And because she got repeatedly admitted with us for the last few months, so every time she used to get one amylase, lipase, lactate. And because she is a nurse by profession, she herself knows. So we need not, she doesn't wait for us to order the investigation. She herself says that sometimes she comes with the investigations and sometimes she requests us to send the investigations. And we have tested our stool also, which is negative for blood, and all routine lab studies, including celiac serologies, endoscopy, colonoscopies with random biopsies, were all normal. The biopsies we have done because every time, because she had these loose stools and we wanted to rule out any other parasitic manifestation, parasitic infestation, or some microscopic colitis and all this. So we have done general biopsies, random biopsies from the stomach as well as from the ileum and the colon. So for some reason, because she had loose stools, someone had advised her to do serum chromogranin, and that was very high. And the more so she became very anxious about this serum chromogranin being very high. It was around 900. So she underwent a CECT abdomen, contrast CT abdomen, MRI abdomen, and this CT abdomen and MRI abdomen were all normal. And because the serum chromogranin was very high, she underwent with a PET Dotanac scan also, which came out to be normal. Because of the giddiness, she underwent a MRI brain, which was also normal. And chromogranin, so what I did when she came to us was I stopped her PPIs for a brief duration, 7 to 10 days. She was on chronically has been taking PPI for 10 to 15 years. So we stopped this PPI and we repeated chromogranin and it normalized. So she had multiple consultations. She visited a neurologist multiple times, ENT, because ENT and neurologist was because of the giddiness, and she also visited a psychiatrist also. So after doing all this also, she was not convinced and she went to AIMS for a second opinion. In AIMS, they saw most of our investigations and they didn't do, then they did not repeat any investigation apart from some hydrogen breath test or 1 or 2 blood tests they have done. And they said, they took the history and they said it's IBS. So they sent her off. So the purpose of discussing, so how to go further in such a scenario. So this is a typical setup for a IBS patient. See the profession of the patient. She's a nurse by profession. Her daughters stay away from her. She works in a cancer hospital. And of late, because her daughters don't stay with her, she might have become insecure in her mind and she thought she's developing some malignancies. So she had done MRI of the abdomen, CT abdomen, Dotanac scan and whatnot. So all investigations had been done and everything was normal. So I will come to the treatment of that patient later. So now from till now, you might have understood that this patient has got IBS. So now what is IBS? So we all know this is the most common disorder that we see in our day-to-day practice. The prevalence of this disease is around 10% with the incidence of around 1 to 2% per year. This is a figure from USA. And this can be labeled as a biopsychosocial disorder where there are 2-3 components like psychosocial factors are there, altered motility is there, and altered sensation is there. So altered sensation means hypersensitivity, altered motility of the gut, and psychosocial factors. So all these are involved in the pathogenesis of this disease. And this disturbs the quality of life, social function, as well as healthcare utilization. So now, of late, if you read the literature, you will find that IBS may not be completely a psychosocial disorder or psychological disorder. There is some organic, so of late, the literature, if you see, it has mentioned that IBS has got an organic component too, might be having an organic component. So in the form that there is a low-grade inflammation going on in the mucosa, in the intestines. So this is a complex interplay between the central nervous system, the enteric nervous system, which disturbs the motility of the gut, and the patient experiences symptoms because of that. And it is also related to the stress, life stress, psychological state, the social support that the patient has. And also it depends on the environment of the patient, the genetic susceptibility, the bacterial flora of the gut, and also food hypersensitivity. So this is a complex, 3-4 mechanisms are there which causes the symptoms. So the current thinking on pathophysiology, as I have discussed already, is the defect in the enteric nervous system, which may lead to the hallmark symptoms of IBS. And the primary thing is visceral hypersensitivity, because of which they experience the pain. And this increased visceral afferent response to normal as well as noxious stimuli. And the mediators that are involved in this is 5-hydroxytryptamine, bradykinin, tachykinin, and neurotropins, and the other neurotransmitters. And this might be associated. And the second component is a primary motility disorder of the GI tract. So if you see the main neurotransmitter that is implicated in the pathogenesis or the pathophysiology of IBS is 5-hydroxytryptamine. And this 5-hydroxytryptamine neurotransmitter, this is highly concentrated in the intestine. At 95% of the 95% of 5-hydroxytryptamine is in the GI tract and is secreted from the enterochromaffin cells, and 5% is from the central nervous system. So what are the effects of 5-HT receptor effects? Are its mediate reflexes controlling gastrointestinal motility and secretion, and it also mediates the perception of visceral pain. So, and when we compare the pain threshold of IBS patients and compare them with controls, as you can see from this curve, from this diagram, that the IBS patients, they have a lower threshold of pain when compared to normal individuals. And this is usually demonstrated by, if you inflate a balloon in the rectosegment region, you see the threshold of the pain is less in patients with IBS. So the same figure, if you compare the pain thresholds, if you see colonic distension with a balloon, the IBS patients will have discomfort, whereas in the same patient, the normal patients don't feel that. And this is usually in the visceral hypersensitivity, whereas the peripheral, if you immerse both these patients' hand in ice cold water, it remains the same. The response is not different, but when we distend the viscera, the response changes. So of late, initially when we were students, like the thing was that IBS is a disease of exclusion, but now there is a shift, and now the stress is more to make it as a positive diagnosis. So we should try to identify abdominal pain as a dominant symptom with altered bowel function, look for red flags and rule out other diseases which can organic diseases, then perform diagnostic test, physical examination to rule out organic disease, make and confirm diagnosis, initiate treatment program as a part of diagnostic approach, and follow up this patient. So the stress should be on making a positive diagnosis rather than just making it as a diagnosis of exclusion. So the red flags which we should keep in our mind are if the patient is anemic, if the patient has got fever, if the patient has got persistent diarrhea, rectal bleeding, severe constipation, weight loss, and if there are nocturnal symptoms of pain and abnormal bowel function, family history of GI cancer, inflammatory bowel disease, celiac disease, or new onset of symptoms in patients more than 50 years. This group of patients, we should be very careful in making a diagnosis of IBS. Though of late, the American College of Gastroenterology has said that there can be nocturnal symptoms in IBS patients. So in history, if there is when you take the history of the patient, if there is weight loss, onset in older patient, nocturnal awakening, family history of IBD, or if the labs hemoglobin is less, WBC increase ESR, abnormal LFTs and all, and if there is abnormal findings on physical examination, then these patients, we should be careful in making a diagnosis of IBS. Now, but still, when we diagnose IBS, there are a few other things which we should keep in mind, like there can be chronic infections like Giardia, amoeba, bacterial infections, so you have to keep as differential diagnosis. Then see in the dietary pattern of the patient, if the patient is on lactose, caffeine, alcohol, fat, gas-producing foods. If the patient has got malabsorption like post-gastrectomy, intestinal, pancreatic disorders. Then other psychological, if the patient has got anxiety, neurosis, depression, somatization, or we should rule out we should keep in our mind about inflammatory bowel disease also, microscopic colitis, ulcerative colitis. and also the other diseases like endometriosis, endocrine tumors, carcinoid and all. So even now this IBD patients, inflammatory bowel disease patients also do have IBS overlap. So we all should keep these things in mind. So the diagnostic approach is establish a symptom-based diagnosis, identify the dominant symptoms like pain, diarrhea, and constipation, consider other clinical factors, then perform a few diagnostic tests, then initiate treatment. Now, if you see the diagnosis according to the Rome criteria, 4 Rome criteria, the Rome 4 criteria says recurrent abdominal pain on average of at least 1 day per week in last 3 months, associated with 2 or more of the following, like related to defecation and or associated with a change in stool frequency and or associated with a change in the form of stool. And this criteria should be fulfilled for the last 3 months with symptoms onset at least 6 months prior to the diagnosis. So to diagnose any patient with IBS, these are the criteria as listed by Rome 4 criteria. Now coming to the management, as I said, establish a positive diagnosis, reassure patient that there is no serious organic disease or alarming symptoms. And in my experience, when you deal with these patients, you should always try to explain the patient the mechanism of the disease and try to take them in your loop and just try to make them understand that there is nothing very serious and they should not be worrying. This is not cancer and this is not going to shorten their lifespan. So you have to talk in that manner to the patient. Then only they will have some confidence in you and get treated, and they will respond to the treatment. So this is the Bristol stool scale. If you want to classify IBS, like IBS constipation, this includes Bristol stool types 1 and 2. Then IBS diarrhea, usually this consists of Bristol type 6 and 7, which is watery diarrhea. And if there is type 1 and 6, then it is mixed, both sometimes type 1, sometimes type 6 mixed. And if you cannot classify the stool in any of this pattern, you see IBS undifferentiated U. So this is the classification of IBS. And this is the differential diagnosis. Already we have discussed this. So now coming to the management. So any management of our GI diseases starts with nutrition. Now low in FODMAP diet should be advised to the patients because FODMAPs are poorly absorbed in the small intestine and are passed on to the colon where they increase gas production. So there is a strong evidence supporting the low FODMAP diet as an effective therapeutic tool in the management of IBS. So the high FODMAP and low FODMAP diet, these are all listed here. I'm not going into the details. You can Google it and everything you will get in the Google. So if you just write low FODMAP diet, so that will be everything will come. Now, very important aspect like gluten restriction. Should we restrict gluten for these patients who have IBS symptoms? So there is no studies and there is no proof. So less certain is the role of another widely adopted dietary strategy, that gluten restriction. So diet microbiome interactions are critical to the homeostasis of the gut microbiome in health, and they may be disturbed in disease. So based on this, the gut and the microbiome interactions, so always there is enthusiasm about the use of probiotics in IBS, but according to the American College of Gastroenterology, the role the IBS in the role of probiotics in IBS is questionable. This does not have much role in IBS patients. So in a nutshell, if you want to discuss the generalized therapy, so if the patient has got a constipation predominant IBS, the first line of treatment should always be a fiber, or it can be an osmotic laxative like polyethylene glycol or lactulose or docosate, sodium docosate. Second line can be bisacodyl, sodium picosulfate, tegaseroid, lubiprostone, linaclotide. I will come to these drugs one by one. And if the patient has got a diarrhea predominant, then the loperamide can be used or diphenoxylate can be used. Then this ramosetron, alosetron, all these drugs can be used. Rifaximin can be used. If the patient has got a bloating, usually in my practice, I use rifaximin, and also you can use simethicone or dimethicone. And for pain, if the patient has got a pain predominant symptom, then usually antispasmodics should be used. There are various antispasmodics, which I will discuss. And also antidepressant, tricyclic antidepressants can also help in decreasing the pain. Now coming to the role of ramosetron, 5-HT3 antagonists in IBS. So this is a drug which is usually used for diarrhea predominant IBS. And the clinical evidences are there are various guidelines like the WGO, World Gastroenterology Organization IBS guidelines. They say ramosetron is an effective drug for IBS diarrhea. and appears to be avoid of serious adverse effects. The second Asian consensus also IBS said the same thing. The Lancet in 2020 reported ramosetran is effective in IBS with diarrhea, and IBS with mixed stool pattern. Its effectiveness is supported by high quality of data. And the Japanese, the American Journal of Gastroenterology, as well as the British Society of Gastroenterology, all have recommended ramosetran for the treatment of IBS diarrhea. Now, what is ramosetran? It is a highly selective, long-acting 5-HT3 receptor antagonist, because as you know, 5-hydroxytryptamine, this increases the gut motility. So we have to give a antagonist so that the gut motility decreases and the diarrhea also decreases. So when there is stress or increased intracolonic pressure, serotonin is released. This is greatly related to GI motility, secretion, and sensation. Then this works on the enteric nerves, induce the acceleration of intestinal transit and diarrhea. And also it stimulates the intestinal nociceptive transmission to CNS, and abdominal pain can occur. So if we give ramosetran, both these arms can be inhibited. So the dosage is usually 5 microgram and the maximum dose is 10 microgram. So the clinical evidence, this is a study from Japan, I think. Yeah. It is a randomized double-blind placebo-controlled clinical trial of the effectiveness of novel serotonin type 3 receptor antagonist ramosetran in both male and female Japanese patients with diarrhea-predominant IBS. This was a double-blind placebo-controlled study, and the conclusion of the study was, if you see from this diagram, those patients who received ramosetran in the dose of 5 microgram had better response. That means the global IBS symptoms have improved in them when compared to the group which received placebo. So also the same thing is depicted in this diagram. The patients who are treated with ramosetran, they have a better response of global IBS symptoms when comparison to placebo. So to conclude, this study said ramosetran hydrochloride 5 microgram once daily is effective and well tolerated in the treatment of abdominal pain, discomfort, and bowel habits in patients with diarrhea-predominant IBS. So this is another study. This was a phase 2 trial of novel serotonin type 3 receptor antagonist ramosetran in Japanese male and female patient with diarrhea-predominant IBS. And this study compared 5 microgram and also 10 microgram dose along with placebo. And this study reported that as for safety, there was tolerability at doses up to 10 microgram, and but the response was same as in 5 and 10 microgram. So 5 microgram usually works the same as of 10 microgram. So ramosetran is an effective and well-tolerated treatment, not only for female patients, but also for male patients. So next group is the antispasmodics and the spasmolytics. This directly act on the smooth muscles, and the various drugs in this group are mevabrine, hyoscine, and simetropium bromide, and clinidium bromide, and octylonium. So mevabrine in IBS, it has got a normalizing effect in the small bowel in IBS, enhances contractile activity in the similar fashion to prokinetic agents, and it produces alterations in motor activity consistent with an antispasmodic effect. So this is the mechanism of mevabrine: calcium channel blockade, inhibition of contractile pathway in the gut, antagonization of excitatory neuromuscular neurotransmission, direct smooth muscle relaxation, and increase in the colonic transit time. So the smooth muscles, normally this acts in this calcium plus calmodulin. This works on the light chain kinase, myosin phosphatase, myosin P actin, and contraction. So this area is inhibited by this mevabrine. So it has got a dual action, like it's directly acts on the smooth muscle cell. It's a smooth muscle cell relaxant, and it inhibits excessive smooth muscle contraction in the GIT by lowering calcium in smooth muscle cells of GIT and relieves spasm and abdominal pain. And it also reduces excessive motility. So as an antispasmodic, there is a rationale of mevabrine in IBS. It suppresses the contractile response to stimulus, stress, meal, etc. And also it reduces the motility in response to fatty meal. And it can be also used for acute exacerbations like postprandial pain. So this is the American gastroenterological recommendations for pharmacotherapy. And for pain and bloating, and particularly when symptoms are exacerbated with meals, antispasmodic medication should be considered. And in clinical practice, antispasmodics and anticholinergic agents are best used and needed basis up to 3 times per day for acute attacks of pain or before meals when postprandial symptoms are present. So for IBS treatment, a concise diagnostic evaluation and prompt institution of symptom-guided therapy can help alleviate the pain and suffering experienced by patients with irritable bowel syndrome. So next, coming to another important drug, that is rifaximin for patients of IBS without constipation. So this was a landmark study called Target 1 and Target 2 study, which was published in NEGM. And here the doses used was 550 milligram 3 times daily in comparison to placebo at 2 weeks, and they were followed up for additional 10 weeks. And if we come to the outcome, the results, almost more than 1,000 patients were there in both the studies, 600 in each group. 1,200 patients are there, and the studies were conducted in 2008 and 9. And if you see the treatment response, both in Target 1 and Target 2 studies, there is a significant difference between the placebo group and the rifaximin group in improving the symptoms of the patient, that is diarrhea predominant IBS. The primary endpoint as well as the secondary endpoint, like the daily global IBS symptoms, all improved significantly when these patients were treated with rifaximin. So this diagram also depicts the same thing, the improvement of symptoms when rifaximin is used in comparison to placebo. So the safety profile of rifaximin was similar to that of placebo. There is no adverse events. So this study concluded that the result of these two studies showed that treatment with rifaximin at a dose of 550 milligram 3 times daily for 14 days provides better relief of symptoms of IBS than does placebo for up to 10 weeks after completion of therapy. Now, there are various other modalities of treatment like mind-body therapy, hypnotherapy, cognitive behavioral therapy. I'm not going to the details of this. So I'll discuss few new drugs, like one is tegaserod. So tegaserod is a drug which was initially there in the market. Then this was withdrawn for cardiac concerns, but again reintroduced after proving its safety. So it is usually used in IBS-C, and it stimulates the gastrointestinal motility. And it is a 5-HT4 agonist, and the dose is 6 milligram orally twice a day, and it's available in India. Then lubiprostone, this is also available in India. This is an analog of prostaglandin E. It selectively activates type 2 chloride channels, and the dose is 8 microgram twice daily, or you can go up to higher doses also, like 16 to 24 microgram, and it stimulates chloride secretion along with passive secretion of sodium and water. Then this is another drug called linaclotide. This is a guanylate cyclase C receptor agonist. It was approved in 2012. The dose is 290. This is not available in India. So this is also used in IBS-C. Then this is another drug called plecanatide. These are all there in the American College of Gastroenterology guidelines, but this is not yet available in India. But this can be used in those patients who has IBS, constipation predominant disease. Because this the mechanism is again same. This has chloride channel. This is increases luminal chloride and fluid secretion. Then these are there are a few other new drugs. I'm not going into the details of this. I think one is tenapanor. It is an inhibitor of sodium proton exchanger. Then spumacetrac, 5-HT4 HT3 receptor agonist. Etopride is also there. As we know, etopride is not a new drug. Then there are some bile acid sequestrants, but the latest guideline by American College of Gastroenterology and the American Gastroenterological Association has said that there is not much role of bile acid sequestrants in the IBS patients, and should not be used. These are available in India, but we also clinically we don't use this also. And this is another drug which is used for IBS diarrhea predominant. It is a iloxadoline. This is a mu opioid receptor agonist and delta opioid receptor antagonist. The doses is 75 to 100 milligram orally twice daily, and the side effects are constipation, nausea, and abdominal pain. It's not available in India again. So this is a mu opioid receptor agonist. Then peppermint oil, this came into the market, but of late, I don't think this has found much effect in the treatment of IBS patients. But the guidelines, American Gastroenterological Association says that peppermint oil can be used for the alleviation of pain. This is usually used for the alleviation of pain, and it decreases post-inflammatory visceral hypersensitivity, and also decreases abdominal pain and increases quality of life. So this was about IBS. So to end my talk, so the several drugs which target an expanding repertoire of pharmacological targets have been approved or are under development for treating functional bowel disorders in humans. So these agents target the underlying bowel disturbances, supplemented when necessary by management of pain. As new agents are developed, their incremental utility over existing compounds should be evaluated, and several newer compounds are being developed and tested in clinical trials. So this was about my talk in IBS, and I would like to share a little bit about my patient whom we treated. So this patient, after she went to AIMS also, then she came back to us again, and there was not, so what we did was we treated her with rifaximin, and also we treated her with tricyclic antidepressants like amitriptyline, and some symptomatic relief with PPI on and off, and with that she improved and she is doing okay. But intermittently she has got this pain abdomen, and she gets, and the pain abdomen is usually controlled with these antispasmodics, the newer antispasmodics we have used in her, and she is doing okay now with this treatment. So this patient which I had described has got a IBS diarrhea, IBS-D, and the various treatment strategies in this patient can be, we can use rifaximin, we can use ramosetron, depending on the availability and depending on the patient, and because she had pain, antispasmodics and tricyclic antidepressants. So these three drugs, with these three drugs, she improved and she is doing well now. So thank you. So if there are any questions, I will be happy to take the questions. Thank you.
Yeah, thank you so much, sir. Thank you so much. Now the session is open for question and answer. So you type your question in the chat box, so sir can answer your question. And you can also unmute and speak your question. Also, because I mean to say that you can ask question directly to the sir also. So we just wait for the question, sir. Sir, I would like to say, because you have went through your presentation. So, sir, if you sum up the point what you have discussed about that, and we know that there could be the subtypes of IBS diarrhea and IBS constipation. What could be the message from you to the audience?
So the message is, the IBS is a common disorder. This is a disorder which we see every day in our practice, and this is the bulk of our practice is all IBS patients or functional bowel disease patients. Now, if you go by the Rome 4 criteria, that includes abdominal pain, but in Indian patients, pain may not be there. But without pain also, IBS can be there, because as per Rome 4 criteria, there has to be pain to diagnose a patient with IBS. But Indian patients, as has been noted, as has been described in our studies from Indian patients, pain may not be there also. So that one thing you should keep in mind. And next, whenever a patient comes with these symptoms, what we should do is just to keep ourselves, like another thing is we should not ask for endoscopy, colonoscopy always in these patients. So if the patients have red flag signs, or above the age of 50 years, they present first time with symptoms, then you ask for investigations, or otherwise you do some routine investigations like blood counts, thyroid, and a few other serologies and all this, and then treat them in a symptomatic way, try to make a positive diagnosis. It's not always like a diagnosis of exclusion, and try to categorize the patients, whether the patient has got IBS diarrhea or constipation predominant, and treat accordingly as for the drugs available. A lot of drugs are there in the literature, but those all are not available in India. So what we have good drugs. We have ramosetron, we have rifaximin, then we have very good antispasmodics, which can take care of the pain component. Then for constipation predominant patients, we have drugs like propilopride. Then we have drugs like fibers. We can give laxatives, and with that we should manage. And the most important thing is to take the patient into confidence and try to explain to them that this is not a life-threatening disease. This is not an organic disease. It's not a life-threatening. Nothing will happen to you. So all this is very important. You should try to explain the patient the disease. That should be done. If you don't do that, the patient won't get confidence on you, and they would keep on coming to you.
Dr. Paul, good evening.
Yeah. Good evening.
Good evening. I'm Guma. I'm basically a pediatric gastroenterologist, but we get us with a lot of IBS phenotypes in adolescents also.
Yes.
So I have just two short questions for you. One is that should we not rule out celiac in all cases of IBS-D? as per AGA recommendation also, if I can remember. And second is that some IBS patients, due to their chronic symptoms, they have some underlying endogenous depressions also, and they have an undocumented weight loss, or sometimes weight loss
Yes,
may not be amounting to more than 10%.
Yes.
So should we rule out microscopitis to be on the safe side in these patients? I mean, doing a colonoscopy and taking some random biopsies. I mean, what is your opinion and experience? And I would, if you permit, I will ask a last short question. I mean, last question. That
Yes.
Yeah.
which of the newer drugs you are using now, other than this mebeverine, amitriptyline, rifaximin, any of the newer drugs which you are using
Yes.
as per?
Yeah.
Sir, thank you.
So about this celiac serologies, the American Gastroenterological Association has said, if you read that you have to rule out celiac disease in patients before diagnosing IBSD in diarrhea predominant patients. But yes, again, in Indian patients, as we know, celiac in our, at least in our part of the country, in the eastern part of the country, celiac disease is not very rampant, though it is present in the northern part of our country. But again, if it is a diarrhea which is not responding to your drugs, whatever we treat symptomatically the patients, and if the patients present early, and if there is this history, typical history that on taking wheat products or after weaning the patient had diarrhea and all those positive histories should be there to test someone for celiac. Again, celiac will have other things also. A patient of celiac disease will be anemic. A patient of celiac disease will have some growth retardation, all those things. So it should be a constellation of symptoms which should help us to make the diagnosis. And if it is a diarrhea, anemia, which is not responding to the usual therapy, usually we do celiac serologies, and also we do a D2 biopsy from the duodenum to diagnose that. Next, about the third question you said about the newer drugs, about the antispasmodics. Yes, I have been using a lot of pinavarium and otilinium bromide. So because what in my practice, what I do is, first when the patient comes with pain, I start a mebeverine. So few patients, they might respond to mebeverine itself. If they don't respond to mebeverine, then usually next line, either I prescribe otilinium bromide or pinavarium. So in my practice, in pinavarium is a very wonderful, I didn't show those studies. Pinavarium is a very good antispasmodic. Most of the patients, they respond to pinavarium. And I remember your second question now. The second question was about this red flag signs. Yes, it's mentioned in the American the guidelines also. Like a lot of patients, they have said can have nocturnal symptoms also, and mild amount of, they might have a weight loss also because of these IBS symptoms, because of the presence of psychosocial factors. They may not eat well, and when they are not eating well, they are bound to lose weight. So not necessarily, it's not a, so that mark is there, like if the patient loses more than 10% of weight in the last 6 months, then we have to evaluate him. But otherwise, the weight loss may be 1 or 2 kgs or 3 kgs, 4 kgs. But yes, that can be there. Nocturnal symptoms also can be there, and weight loss can also be there in IBS symptoms, in IBS.
Thank you so much, sir. Any other question, audience? Could you ask any other question you have? You can type or you can speak to sir directly.
Since there are no questions till now, so can I have the pleasure to ask one more question?
Yeah, sure. You can go ahead, sir.
Sandip, so how long you continue your patients on mebeverine? Because the symptoms will recur once they're off. Because what is my experience in the adolescent patient? So till 2 weeks or 3 weeks or 4 weeks, we continue mebeverine. They are fine, and they say that less symptom. And even I have seen a very good response to amitriptyline also in I mean slightly older children like 15, 16 years. So but I usually continue it up to 3 months, and after that I try to withdraw. So what is your experience? I mean, when do you, how long you continue this?
So yeah, so after giving for a definite period like 1 month and 1.5 months or 6 weeks, 4 to 6, usually I ask the patient to come after 4 weeks or 6 weeks. Then if the pain subsides, I gradually reduce the dose. Suppose we prescribe it twice daily, then we tell them that you take once daily now. After that, we ask them to take alternate days or after 2 days. Then slowly try to come down on the dose. If you stop, they will again come back to you. Same with PPIs. And same with antispasmodics. So what I tell them is, you keep the drugs with you. suppose initially I gave them twice daily, then I tell them you take now once daily for 15 days, then make it alternate days, then increase the gap, take it after 2 days, take it after 3 days. After that, I tell them you keep them with you at home. Whenever you feel there is some crampy pain is there, you can take one drug. Same with PPIs. Otherwise, this very difficult to come out of the drugs. And the other thing is it becomes habit forming for some patients. And the other aspect is if you stop them completely at one go, again they will come back after a few days that I have again the symptoms.
Yes, because I have the privilege that after 18 years or 20 years, I can refer to them to you. So how you manage for 10, 20, 30, 40 years with IBS pain, IBS-D, it's very difficult, I think. Because
yeah, sure. But usually amitriptyline I avoid in younger patients because some sedation is there, and you don't know that might be habit forming, prescribing someone amitriptyline. Usually these drugs which can induce sleep and which has got addictive potential and all, usually I preserve it for older patients, more than 50, more than 60. At ease, I give them. At liberty, more than 50, 60 years at liberty, I give them. You take, no problem.
Yes, sir. But as per our pediatric guidelines also, because we find a lot of functional abdominal pain, so amitriptyline can be prescribed after 6 years. I mean, 10 milligram does not cause constipation also. So it can be safely used in diarrheal type and constipation type both. I mean, that is what our guidelines say.
The sleep thing, that the patient
25 milligram is more sedative, but 10 milligram, I think it's not very.
But believe me, few patients after giving 10 also they come and say that I slept for I didn't the whole day drowsy and all.
That we have to counsel that initially you may have this and later you may have some adaptation to that.
Yeah, I agree with you. Correct.
So I get a question, and I think so. I'll take 1 minute, sir, of your. Then we can go for the formal closing of the session. Audience, could I get a question? Any more question from your side? So we go for a formal closing. Thank you so much, sir. We go for a formal closing. Could I have the slide, please? Santosh? Yeah. Srikanth, could you show the slide?
Yes, Dada. That's right.
Yeah. Just hold on. Now you can start. Yeah, Santosh, over to you.
Yeah. Good evening, everyone. On behalf of Zydus, I, Santosh Dumpeti, would like to thank you all for your active participations. And I would like to thank Dr. Sandip Paul for his wonderful presentation. It is indeed our privilege to listen to you, sir. And last but not least, my thanks to entire participating clinicians without whom the event would not have been successful. And it goes without saying that we will continue to rely on your affection and support now and hereafter. Thank you. Have a great weekend. Good night and stay safe.
Yeah, thank you so much, sir. Thank you so much. It's a very wonderful talk. Thank you so much.
Thank you, sir.
We are obliged,
Thank you so
sir.
much.
Thank you so much.
Thank you. Good night.
Have a good night. Good night. Could you close the meeting, please?